Nearly 2 years ago to the date, I received a call that my colleague had fallen sick. I was being activated from backup. I went to work the following day like it was any other day, but of course it wasn't. I'm a doctor, specifically a general internist, board certified in Canada and the US, and I work in Toronto in Sault Ste. Marie. In these early days of the pandemic, we were beginning to see patients come into hospital with COVID-19. And before I get too far ahead, I should explain something that I explain every holiday party. What on earth is a general internist? With the pandemic, the explanation became simple. I look after patients when they're hospitalized with COVID-19. On that day in March of 2020, at the hospital I worked and at hospitals across the country, we're beginning to see patients present with confirmed and suspected COVID-19. The turnaround time for test results spanned multiple days, so during this period of time, we had to assume that patients had COVID if they had symptoms or recent travel. We took the necessary precautions to protect ourselves as healthcare providers. And in these early days, believe it or not, I taped off my condo, as I'll show you in this slide here. I taped off my condo, as you'll see in this slide here. Everything to the left of the duct tape was my fiancée Brittany's side. Everything to the right of the duct tape was my side. Of course, this seems crazy now, but what I was most terrified about was bringing the virus home with me and infecting her. You see, in the early days of the pandemic, we had no effective treatments for COVID-19, and vaccines, well, they didn't exist. I remember being urgently paged to reassess a patient who I had admitted to hospital the day prior. He was my age and otherwise healthy. He presented with COVID-19. I had seen him in the morning. He was on a small amount of oxygen, and as the day progressed, he was on 100% oxygen. We urgently transferred him to the intensive care unit, where he was intubated and placed on life support. For me, this was the holy shit moment. I knew that at that point in time, nothing else I was working on or doing really mattered anymore. In addition to being a doctor, I'm also a researcher. My exact area of expertise is clinical epidemiology and machine learning, a type of artificial intelligence. After 16 some odd years of university, my exact job title was clinician scientist. I spend 80% of my time doing research and 20% of my time looking after patients when they're in hospital. I put my research program on hold, and we transitioned all of our attention and focus to COVID-19. We are interested in understanding why some patients come into hospital and do relatively well, while others do not. We also created a clinical trials infrastructure so that whenever a patient was hospitalized, they would have access to potentially life-saving treatments for COVID-19. You see, in these early days of the pandemic, things were looking bleak. There were outbreaks affecting long-term care homes across the country. And the mortality rate, that is the risk of dying, if you're in one of these outbreak settings in a nursing home, is over 30%. In contrast, when somebody comes into hospital with a heart attack, the risk of dying is closer to 5%. This next picture I'm going to show you is difficult to look at, I know, but it captures what was going on in the early days of the pandemic. This is a photo taken in the spring of 2020. The death and destruction caused by COVID-19 motivated the scientific community, especially in terms of how could we prevent these outbreaks from occurring. And that is what I'm going to talk to you more about today. But before we can understand that, we need to know the landscape of what things looked like prior to COVID-19. So in long-term care homes, to prevent outbreaks, one of the best possible approaches is vaccination. We know that every year there are countless outbreaks that occur, most often from viruses, parainfluenza, RSV, influenza. For many of these viruses, no vaccine exists. And in the case of influenza, the uptake is modest and its effectiveness is also modest at best. We are so incredibly lucky that with COVID, we have life-saving vaccines. They prevent the risk of dying or severe illness by over 90%. But what we've learned over time is that their ability to prevent disease, that is the transmission of disease from person to person, pales in comparison. We also know that the effectiveness of the vaccines, they wane over time. So clearly we need proactive strategies. And in the setting of COVID, we did have more proactive strategies When individuals visited long-term care homes, they would have to perform a rapid antigen test, same for the workers. We also had outstanding rates of vaccination among residents of long-term care homes. But still, outbreaks continued, and to this day, continue to occur. So clearly, we need more proactive and more innovative methods. One of the more innovative methods you might have heard of is wastewater surveillance. Wastewater surveillance takes advantage of the fact that the virus, when somebody's infected, is shed into their feces. So what is wastewater? Well, every time you flush your toilet, wash your hands, run the sink, all of that water collects and eventually becomes wastewater. So what we can do is we can recover the virus from this wastewater to quantify the burden of disease in a given region, a given area. This is clearly innovative, and it's also potentially proactive, but the drawback is it lacks spatial resolution. And yes, it's non-invasive. It doesn't affect any of our daily lives. But again, you can't drill down to know, is it this building we're in right now? Is it the building across the street? Instead, the results are reported on a municipality level. It would be ideal if we were able to bridge the gap between wastewater surveillance and individual level testing. And I believe that bridge is right in front of us on the floors. I learned about this with a call with my good friend Derek McFadden, an infectious diseases doctor in Ottawa. He and his team were pioneering a new approach to leverage and identify if whether or not swabbing the environment around us could help to identify an outbreak before it occurs. This idea that the environment around us plays an important role in the transmission of disease or as a reservoir for disease is not new. It dates back to the 19th century. Made most famous, the first and most famous example, is during the cholera epidemic in London, England. Dr. Jon Snow and his team, no relation to the Jon of Snow from Game of Thrones, identified that there was a specific region in London, in the Soho district, where there's a large number of cases of cholera occurring. As they surveyed the region, they spoke to affected and infected residents, they found a common theme. And that's that nearly every individual accessed their water from the Broad Street pump, which is pictured here. It was later realized that this Broad Street pump was drawing on a water source that was contaminated with cholera. This, of course, was because we didn't have effective sewage systems in the 19th century. Fast forward now to 2004, and we have the technology available to identify these pathogens from the environment. And when I say pathogens, I mean bacteria, viruses. You see, each of these organisms has their own genetic code. Think of it as their fingerprint. One of the first studies to look at whether or not we can identify the bacteria in the environment occurred in 2004, and specifically it looked at shower curtains. It turns out our shower curtains are a breeding ground for bacteria. That pink discoloration you might notice at the base of your shower curtain, it turns out those are byproducts from a bacteria, specifically a biofilm. And if you think that's gross, keep in mind that as humans, we have more bacterial cells in and on us than we do human cells. Every day, every hour of the day, right now, we are all shedding bacterial genome copies into the environment around us, over 30 million per hour. And our work takes advantage of this fact and recovers these, specifically the virus, from the built environment. So when I say built environment, what do I actually mean? I mean the environment around us. The floor in front of us, this TEDx sign behind me, all of these fall within the built environment. And what the team in Ottawa had done, they had recognized and realized that as the burden of the virus increased in hospitals, so too did the amount of virus that could be recovered, specifically from the floors. They also swabbed other areas, keyboards, desks, chairs, etc., but it was mainly the floors where the virus could be recovered. I joined the team a year and a half ago, and the team's name is CUBE, COVID in the Urban Built Environment. And our tagline is simple: why swab feces when you can swab the floor? So let's actually walk through how this works. I should make it clear, you can't get the virus from the floor. Instead, what we know is that the virus can remain active and viable maybe for a few hours when it touches a surface, but for many days thereafter, we can recover the genetic material. So again, the virus doesn't spread from touching surfaces. Instead, the virus spreads as we talk, cough, sneeze. we shed droplets and aerosols into the environment, and like everything else, gravity will bring that down to the floor. Most often, the spreading occurs when people are asymptomatic. They're walking around not even realizing they're infected with the virus. In that sense, you can think of the floor as a reservoir or as a sink that just soaks all of this up. And that is where the fingerprints lie for the virus that caused COVID-19. So you're probably wondering, okay, so how does this actually work? Well, first we take a swab, but rather than swabbing somebody's nose, we swab the floor. We then transfer that swab into a buffer solution, this purple-looking panel here. What the buffer solution does is that it inactivates a virus, but it preserves its genetic materials. We can then transfer this to the lab, and at the lab, we can extract the virus if, of course, it was present from our swabs. So we remove all of the excess material, and then what we're left with is just the virus. But we're talking microscopic amounts of information. So now comes the detective work. The detective work involves a technology called PCR, polymerase chain reaction. It's a confusing topic, so I'm going to sugarcoat it a little bit. But remember, we know the virus that causes COVID, and we know the genetic sequence for that virus. We can order it to the lab, and we can order its individual genetic makeup and add it to the samples. If there are complementary pairs in the samples that we've collected from the floor, that means a virus is present there. But again, we're talking microscopic amounts of information. So we need a way to amplify that, and that's what PCR does. Think of it as an incredible magnifying glass to determine what is there. So over the past 7 some odd months, we've been swabbing in long-term care homes, daycares, schools, university buildings, just to name a few. And the results from the long-term care homes, I think, will intrigue you. Right now, we're swabbing in Ottawa, Toronto, and Sault Ste. Marie. So what have we actually found from the long-term care homes? What we've identified is that you can detect the virus on the floor multiple days before it's realized that an outbreak is about to occur. In addition, as the outbreak worsens, we detect more and more virus from the floor, and as the outbreak wanes, as it gets under better control, we detect less and less virus. All right, so a lot of information. Let me summarize the 2 most important points here. First, it appears as though we can detect the virus from the floor days before an outbreak occurs. This suggests that this information might be useful to prevent an outbreak. And secondly, we can use it as a monitoring tool, potentially, to determine, is the outbreak getting worse, or is it instead improving? I think this information, this approach, is more important now than ever before. In Ontario and across the country, we've more or less removed all of the protections that have been put in place to prevent the spread of this virus. I think it's particularly important that we think about the most vulnerable individuals, especially those in long-term care homes. Wastewater surveillance data is incredibly helpful. It allows us to get a sense in a given region, are we seeing more or less disease, but it doesn't provide the spatial resolution to potentially make this information actionable. Right now, our team is expanding to additional sites across Ontario and soon Quebec and Manitoba. I think it's really important for me to mention that I am just one single member that's part of this incredible team of individuals. This team includes medical students, graduate students, biologists, evolutionary biologists, architects, ventilation experts, infectious disease doctors, epidemiologists, general internists, just to name a few. As I reflect back and think about all the patients that I've cared for and the patients who've died, I think about them and I think about their family. When we hear about the deaths caused by COVID-19, this information is presented to us in the aggregate. We get daily numbers of information. These numbers are necessary to preserve anonymity and privacy, but they obscure the fact that these numbers were people. As a scientist, as a doctor, and most often as a person, most importantly, as a person, I hope that this new approach can help to prevent outbreaks and the deaths that they can cause. Thank you.